So welcome back to the show,
Hey
Dr. G.
Jessa, how are you today? It's
I'm
like
good.
4 in the morning in San Diego.
Not quite, but it is early. It is early. All right. So PGAD. What what does it stand
So
for? What is
where
it?
Jessa, where were you in 2001? What were you doing? That's 23 years ago.
My son was being born. I was pregnant. Yeah.
So there was an amazing sex therapist, and she saw individuals with these unusual complaints of being turned on all the time. It was Sandra Lieblum is was the first president of ISWISH. She's a good colleague of mine. She was at Rutgers. She was with a colleague who was sort of this brilliant guy and developed the International Index of Erectile Function. So Rutgers was the hotbed. Rutgers actually had, at that time, one of the first sessions of teaching medical students sexual activity. So they had
Oh, wow.
sex, and it's since disappeared as there's very little education to medical students. But so Raymond Rosen or Ray Rosen, Sandra Leland were the hotbeds of sex stuff in Rutgers, New Jersey. Anyways, in the year 2001, she reports this, but she's the therapist. There's not many people interested in women's sexual health in 2001.
Right.
And I'm in Boston, so well, I'm not further in Boston, but I was previously in Boston, and now we're in beautiful San Diego, which is like
An, up,
amazing.
an upgrade. Yeah.
A bit of a major upgrade. But I was getting all of these women with these turned on things from the very get-go. It's the nightmare of life. You can't live. The irony is you think, wow, how cool would it be
Yeah,
to
exactly. Why is this a problem? Right.
why
Yeah.
is this a problem? But you can't function, you can't concentrate. I had physicians who, in the middle of conversations with patients, sitting right in front of them, are having orgasms. I mean, that's just awful. And it's demeaning, it's embarrassing, humiliating. It's one of the worst nightmares of life is to have unrelenting, unwanted, persistent genital arousal. And yeah, nobody understands it. I remember going to meetings where I would present this, and some doctor would raise his hand and say, "I wish my wife would have this." I mean, it's just so stupid how.
Yeah. Yeah. Is it
How
only a female experience?
no, God, it's probably a little more in women, but we see tons of men. Although at the time in 2001, the only individuals we were seeing were those with vulvas.
Mhm.
But we didn't know what to do with them. We focused primarily on suppressing sexual activity with medications. That was our big thing. Tramadol, which is an opioid, and opioid is an inhibitor, was our big gun. We learned that Ambien, which is kind of a sleep medication, but
Mhm.
it also has the ability to suppress. We were using Lyrica or pregabalin and then gabapentin. We were using amitriptyline. We were using things that inhibited sexual activity. Our thought at the time was this was primarily a brain sort of mismatch in excitatory versus inhibitory chemicals, that there was way too many excitatory chemicals. And what we had to do was provide inhibitory chemicals. And it kind of worked, but it kind of made people have a lot of side effects from
Yeah.
that.
It sounds a little bit like throwing spaghetti at the wall, right? Let's just
Yeah,
try anything we can think of.
yeah, we weren't very good at it. And interestingly enough, the original description was called PSAS, not PGAD, and that was even worse because Sandra called it persistent sexual arousal syndrome because they were turned on all the time,
Right.
but they weren't sexually aroused in the context that you would
Ah,
usually.
okay.
They could be shopping, they could be swimming. I mean, there's nothing sexual about what anyone was doing.
Hmm.
Oh, under duress from very upset patients. And a few years later, probably 2005, 2006, she changed it to PGAD from PSAS. But I mean, at the end of the day, it didn't change very much.
Right.
Looking at genital versus sexual arousal just was a nomenclature. It wasn't better understanding. The field progressed over time. More and more people were writing about PGAD, and we were getting more and more frustrated because we were just band-aiding the condition.
Hmm.
The biggest breakthrough, I mean, I was editor of the Journal of Sexual Medicine for 10 years, editor of another journal, Sexual Medicine Reviews, for 10 years, and another journal, International Journal of Impotence Research, for 2 years. So I've been an editor for a bunch of years. And one paper came in, I'll never forget it, 2012, which amazingly enough was from Rutgers, although not from the psychology department, it was from the neurophysiology
Okay.
region. His name was Barry Komisarek. He's brilliant. He's basically the scientist who studies orgasm the most with objective functional neuroimaging studies, and he's at the time was unknown to me, but soon after his paper, we got to know each other and we became very, very close. So in 2012, he took a support group of women with PGAD. So, um, in a sense, as you're doing, sharing medical information with the community, another way to do it was to support, was to have groups where
Right.
patients could communicate with each other. So he got cooperation from the group to send Dr. Kamazarek pelvic MRIs if they had PGAD. And he was just going to look at them. And he had a neuroimaging colleague, and he read that something in the range of, I'm going to say 60 or 70% of the women who had PGAD had abnormal pelvic MRIs, and they've had these little cystic dilations in their region of the spine called the cauda And the name of these cystic dilations was called a Tarlov cyst. So I received this paper that women with PGAD have a higher prevalence of Tarlov cyst than women who don't have PGAD. And I said to Barry, I don't even know what a Tarlov cyst
I was just going to say, could you explain what this
is.
what this means?
Yeah, so I said to Barry, you appreciate that if we publish this, and I guess we'll publish it because it looks like good science. Uh, everybody's who has PGAD is going to have to get a pelvic MRI. Are you sure this is real stuff? He said he's 100% sure it's real. So all nerves in the body end up in a pathway to the brain. I mean, that's obvious.
Right.
And then the ones in the genital pelvic area have to go through little tiny holes. Let me see if I can show you a hole. There's a hole. And
Right.
these are called foramina. And there's four of them. I'm showing you two holes in the sacrum bone. On the
Okay.
left side, so it's S4, S3, S2, S1, and there's a right side and a left side. So the nerves of the pelvis, so there's the pudendal nerve, there's the pelvic nerve that does the inside of the bladder, inside of the uterus, inside of the vagina, inside of the, all the pelvic organs, inside of the rectum. So pressure. The pudendal is sensation from the genitals, and then the sciatic nerve. So your legs also go
Hmm.
through those little holes. And then they merge. There's way too many nerves, and you can only have so many what we call nerve roots. So the nerves ended up as nerve roots. So three
Right.
nerves ended up as one nerve root, but
Okay.
the individual nerves were merged within this nerve root. And all nerve roots are surrounded by a layer called the dura, D-U-R-A. And there's fluid traversing underneath the dura in front of the nerve, keeping the nerve healthy.
Hmm.
So the dura, as it travels more towards the actual opening, gets a little weak. It's not as thick. It's more thick sort of within the region called the cauda, but it's less thick as it just enters. So there's a region where it can form an aneurysm, a weakness, and
Okay.
the fluid ends up going in here. So I'm going to draw a Tarlov cyst. Yeah, so there's
Oh, so
dura
there's like a little lump or extension of right.
of the dura full of the fluid. But
Okay.
then it pushes on it's a mass effect. So it pushes on the nerve root, changing its orientation and irritating it. So just think, it's irritating a nerve root, but the nerve root consists of information from the pelvic pudendal and sciatic.
Yeah.
So the pudendal comes from the famous clitoris and the labia and the vagina and the hymen and all that area. So you have irritated nerves that you think are coming really from the clitoris, but their actual trigger is
Yeah,
in the
yeah, nothing's
body.
happening at the actual
That's so
genitals. Yeah.
confusing. These women have my clitoris is turned on, my clitoris is sore, my vagina feels like it's lubricated. Well, it does, but nothing's coming from that area. The
Yeah.
true trigger is in the caudate gland. It's called remote. Another way to think of it is if you understand the term sciatica, there's a condition called lower extremity sciatica, where you get pain shooting down the leg or vibration or hot or something in the lower extremity. But the leg is completely normal. You're
Right.
getting feelings of weirdness in the legs.
Right,
But the
right.
true pathology comes from a disc in the spine. And when you fix the disc, the legs magically become normal. But there's nothing wrong with the leg. So let's call PGAD in many cases clitoral or genital pelvic sciatica. I don't know if
Wow.
that makes sense, but it's absolutely 100% true. So we didn't know that. In 2012, that became evident. But the transfer of that information to the general community took a whole bunch of years.
Yeah.
And then, so in our facility, after 2012, everybody got a pelvic MRI. But the prevalence of Tarlov cyst is actually kind of rare. It's not a very common thing.
Okay.
It's a little more common if you happen to be slipping downstairs and hitting your butt as you go down each and every step, or it's cold and icy in New Jersey and you slip and land on your butt. After a trauma to your butt area, Tarlov cysts are a little more common. So we would get what's called a pelvic MRI, and we would get the pelvis, so the bladder and the vagina and all that stuff in the image. And we would get a little bit of what's called L5S1 and a tiny, tiny bit of L4, L5. But it's we don't get the rest of the lumbar because it's
Right.
the MRI. But we didn't see that many Tarloses, but we were like amazed at how often we saw L5S1 herniated discs and L4, L5 herniated discs.
Ah,
So we flipped and we said, the better study is not a pelvic MRI, it's a lumbar MRI. We could see now all the lumbar vertebrae, and we could see most of the pelvis in a lumbar MRI. So in the year 2024, we tell patients who have PGAD, please, please get a lumbar MRI. And then we run into prior authorizations and doctors saying, we don't know why we're doing this and all this sort of stuff. But anyway,
right.
a lumbar MRI is kind of a critical part of the puzzle because actually it turns out that herniated discs are way, way more common as so remember we talked about the pelvic pudendal and sciatic mixture, three nerves turning into one nerve root.
Hmm.
There's Karloff cyst potential here. But as this ascends, uh,
Yeah.
lumbar disc L5S1, lumbar disc L405, lumbar disc L304, lumbar disc L201 can really bang on.
Yeah, like anywhere up to the brain, right? Could have
Yes.
this
So
irritation.
after it gets past S1, S2, it gets to be where it's a true spinal cord.
Mm.
So the uniqueness of the lumbar areas, they have all of these wires called nerve roots, but they don't talk to each other. They're just individual. They actually travel 15 inches. Actually, the nerve from the clitoris is a single nerve for almost 3 feet, if you think of it,
Wow.
because it goes from the clitoris through the foramina up to what's called the conus medullaris. That's the region where these things connect with the spinal cord. And that doesn't happen to your rib, your
Ah,
lower rib.
okay.
I'll show you. Here's my lowest rib down here.
Right, right, right.
So if I follow it to the back, that's where the spinal cord actually starts.
Yeah.
So we now are asked by my amazing organization, ISWISH, International Society Study of Women's Sexual Health. They have these consensus sort of development process of care groups. And it's one of the amazing features of ISWISH is to propel with guidelines forward how you diagnose and treat all the numerous women's sexual health issues. So I was asked to co-chair with Barry Komisarek this thing on persistent genital arousal disorder. So we meet in Dallas. There's 15 experts. And we say, okay, how can we do all this? And we have a need to nomenclature change. And so we brought in PGAD to that which is called genitopelvic dysesthesia. Just let me not frighten everyone. PGAD was a unique feature. You had arousal, but some
Right.
people have way less arousal and more burning or electric
Yeah.
shocks or itching or throbbing or weird sensations. And we couldn't really call them PGAD, but they were kind of PGAD-ish. So we said, okay, there's an umbrella called weird feelings. And weird
Yeah.
feelings is dysesthesia. It's five
Okay.
syllables. Aesthesia is to feel. An esthetician, an anesthesia doctor doesn't make you not feel.
Right.
Dysfunctional feeling is dysesthesia, and it's specifically genital pelvic. So GPD, genital pelvic dysesthesia. So one of the GPDs is PGAD.
Right.
You
Right.
can
So from
have
that irritation, you might feel a variety of things, one of which would be
one of
arousal.
which is arousal, yes.
Yeah.
So in 2021, when we put these guidelines together, we realized a better way to think of PGAD is in the context of a broader GPD,
Yeah.
because now people who didn't have arousal but had buzzing in their clitoris and itching in their clitoris or their labia were still under that umbrella. And the other big thing we did was we said, okay, so something in the clitoris has to get to the brain. So a trigger for PGAD, there's many people who have PGAD because of something's wrong with their clitoris. So we call that
Mm.
region one, the genitals. Okay. Then there's all these people who are bicyclists and BMX riders and spinners. And if these are their legs, they're jamming
Right.
things
Right.
to their crotchet and voluntarily, which is even more weird. But so you can hurt the pudendal nerve in that area, which is separate
Yes.
from the clitoris. And you have all the muscles of the pelvis, and they get really tight. So there's the pelvic floor region. So it's a pelvic pudendal sort of region. So we call that region two. And then, as we discussed with Dr. Kamazarek and his Tarlov cyst and his herniated disc sort of story, that's region three. And then where the spinal cord starts up to the brainstem, which is where the brain starts, that's region four. And then, of course, region five, which is the original initial 2021, as 2001, Sandra Liebum story that we started at the beginning is the brain, where we
Right.
use medicines to sort of suppress everything. So we now have five regions. So it's called sex detective. A woman comes in with PGAD, and we try to define the one, two, three, four, or five triggers where her
Yeah.
PGAD's coming from, because it doesn't necessarily have to be just one trigger.
Okay.
And we're shocked in the year 2024 to realize how many of the triggers come from the back. It's crazy how, I mean, I'm a urologist, so the back to me is this foreign world.
Right. Some other land.
People get older and they get osteoporosis and they don't exercise very much. Their back goes to bad places, and herniated discs are ridiculously common. The prevalence goes like this with age
Hmm.
of herniated discs, and herniated discs are we recognize as causes. So, anyways, we're now in a much better position. We've now recognized 50 reasons for PGAD.
Wow.
And we have, subsequent to 2021's magic change, life-changing paper, we've now recognized another 10. So we now have 60 reasons for PGAD. And it's just really a matter of who's who, what's what. When we can identify the trigger slash triggers, we can now formulate therapeutic plans that make sense for people rather than just throwing drugs at them and saying, let's suppress all information going to your brain so that you can have a life.
It
How much
sounds,
fun is all this?
well, I mean, it sounds like surgery is the treatment for a fair number of this, right? If it's about herniated
Well,
discs or cysts on the nerve root.
I think taking in context medical management and psychological management and hormonal management should always be tried first.
Yeah.
There's a group of people who do well. I'm going to do something really weird with you now. I'm going to actually, while I'm talking to you, I'm going to open up an email because you just have to appreciate how crazy our life is. And I'm going to read it to you. God only knows if I could find it though. So it's from a woman who was referred to us from my colleague, Andrew Goldstein. And oh, here it is. God, I can't believe I found it. I'm going to read it to you, okay?
Okay.
To everybody, this is a real person. Hello, this came to me October 13th, 2024. Hello, I was a patient of all three of yours from 2022 to 2023. So that's 1 and 2 years ago. I wanted to share how much success I've had and thank you all so much for changing my life with an exclamation point. Dr. Andrew Goldstein, so he's my sort of brother from a different mother
Right.
in the East Coast, referred me to Dr. Irwin Goldstein, that's me, and then Dr. Chol Kim, who's this amazing, life-changing spine surgeon who is able to digest all this sexual information and help and be empathetic to
Mm.
people who have PGAD. And there are very few spine surgeons who
Yes.
possess those qualities. So it says Dr. Andrew Goldstein referred me to Dr. Irwin Goldstein and Dr. Kim in 2022 after examining me and referring me for a lumbar MRI and seeing there was damage in my L4, L5 disc. We just talked about that.
Right.
Okay. Before this, I had had terrible pain, burning, itching vaginally since I became sexually active. Sex was always painful, but also everyday life was also painful. And I would get flare-ups seemingly at random that would make me insane. I tried everything under the sun, but nothing worked. I got the surgery to fix the herniated disc with Dr. Kim in June of 2023. After the surgery, I had one initial flare up, which was expected from the surgery touching the nerve. After that, I have, in bold, never had one again. It's now been 1.5 years since the surgery. I have never had another flare up. I can now have sex without pain. My life has been so transformed by this. For 15 years, I thought I was, quote unquote, doing something wrong to
Mm.
cause this. And I am still in disbelief that it was just a spinal problem and nerve pain. I no longer have to spend my life working around the issue and trying, in quotes, unsuccessfully to prevent it. I wanted to thank you all so much for the work that you do and also offer that I'd be happy to talk to any future patients of yours about my experience. Isn't
Mm.
that a cool email?
It really, really is. I mean,
You
it's
don't
sort
get
of
that every day.
well, you might. I mean, it strikes me how persistent you are in trying to figure out what is actually going on with people, and
That's
let's
my
find it
stupid
and
brain.
deal. No,
I'm
like
a,
deal with the
I'm
real
an
problem.
engineer. I came into medicine as an engineer, not as a doctor. So
Yeah,
I can't get rid of my engineering brain.
because you think about all the women that are struggling with pain or issues going on, and it's like have a glass of wine or take an antidepressant or what nobody. So few people care to get to the root of what's really happening.
So we have many, many success stories. We also have horror stories. We have people who we can't find the problem. And
Mm.
this is the condition for which I've experienced the most suicide.
Ugh,
Uh, Numerous patients have committed suicide because we can't get to the root of the problem. We don't understand it. We try this, we try that, we can't get it. So we're nowhere like 100% of success. I guess there's nothing in medicine like that, but um, um, yeah, it's I call it the nightmare of all of medicine is having this arousal unrelenting and
yeah,
you know patients who have it don't even tell their husbands, they refuse to tell their doctors, they refuse to be pointed out as being sexual when it's not sexual and
yeah,
there's such tragedy with this thing.
yeah,
But the other side of it is in 2001, because I have the history where it was just beginning. We had no understanding of what this was, and now we are better. And that just means as we get more and more sophisticated with imaging and things like that, we'll get even better.
right.
But uh, um, the current philosophy is it's a detective story. Try to figure out, listen, examine. Some of the coolest things we do is let's say the woman comes in with my clitoris is on fire, it's throbbing all the time. I get close to orgasm. Sometimes I'm just walking down the street and I have an orgasm. It couldn't be any more embarrassing and humiliating. Please help me. So we'll do some tests and then we'll put some numbing medicine on the clitoris. Okay. What
Yeah.
I'll ask you, I'll play a game with you. What would you expect happens
You would
when
expect there'd be no sensation, but there probably still is, right? Because it's coming from the nerve
well,
root.
so the clitoris is numb.
Yeah.
We ask the question. So when they touch the clitoris, you can't feel it. So then we say, do you still have these throbbing, crazy arousal pains from your clitoris? Now, if it's coming from the clitoris, she'll say, "Oh my God, you cured me. I stopped. I don't have my PGAD anymore." But if it's coming from the pelvis perineum area, the bicycle riding
Right,
community,
right, right.
or if it's coming from Dr. Kamazarek's region in the back, they'll still have that. Isn't that
Yes.
the most crazy thing?
So
This
are you
clitoris
are
is
you ruling
throbbing.
out, you rule out region one, and then
Then
you
we
go to
go to
region
region
two,
two.
and then region
Then we go
three,
to
right?
region three. So for region two, we put Novocaine and lidocaine with a needle into the nerve of into the region of the nerve. We do what are called pudendal nerve blocks. And some people say, "Oh my God, you've completely cured me." And some people say, "I can't feel anything, but I still have my PGAD."
Yeah.
And then go up to the spine. I can't stick a needle in someone's spine, but
Right.
there's a pain anesthesia doctor who routinely does that. And Dr. Kim tells them exactly where to go and how much fluid to put in and blah, blah, blah. And then after their injection, that's called either caudal epidural,
Hmm.
CADAL epidural for the Tarlov cyst, or TFESI, transforaminal epidural spinal injection, TFESI, where the anesthesia doctor, pain doctor does this under fluoroscopy, sterile conditions, blah, blah, blah. Then they come from their office to our office, and we help the people interpret what the F is going on
Right.
with PGAD. And some like this woman who I shared her email when she came to the office, she says, "Oh my God, I don't have any more PGAD." And then 4 hours later, when all the lidocaine wears off, she says, "Oh my God, I have PGAD again." But this just proves to us that the true trigger was this in the back area.
Yeah. Yeah.
Anyways, it's like I'm saying, it is this weird detective game, but I don't know any other way to do this at this point in time.
Right. Right. Now you mentioned surgery is sort of the last option, which is makes sense. What are some of the other treatments for the? I mean, I guess if there's 60 different triggers, it's maybe
There
it's
are
too much
definitely
to cover in one conversation. But like,
no, I think it's not unreasonable to start as we did in 2001. Give some people some relief by giving them some medicine.
mhm,
Um, uh, there's side effects of medicines, but there's side effects to the PGAD. So it's this balance. It's not unusual for us to sort of do the original treatments and then say, okay, let's continue the evaluation. One of the problems we have with the treatments to suppress the excitation in the brain is when we're doing the testing and we say, okay, here is the lidocaine administration to your clitoris. Do you have PGAD? She said, well, the medicine you gave me stopped most of my PGAD, so I can't actually tell you if your diagnostic test worked. So when we're doing diagnostic testing, we have to stop those medicines so they
right.
have bad situations so we could see if it worked. I mean, it's
Yeah.
kind of a weird thing, but um, it's just a matter of being systematic. So you
Yes.
don't miss anything because every day they have PGAD is another day they have PGAD.
Yeah. Yeah. Well, thank you.
Anyway,
Would you say just a little bit about where people can find you and how they could come under your
well,
care if they want to?
we've moved to probably the finest city in the world. I don't know. I mean, I've traveled through most of the world, but I can't find. Every time I go to the airport, I say, I can't believe I'm leaving this place to go to a place not as nice as this place. So San Diego, the facility is called San Diego Sexual Medicine. It is the coolest facility on earth, 6,000 square feet, with lots of employees who are dedicated to what we do, which is we only do women and men's sexual health issues, or individuals with vulvas and penises sexual health issues. And that's all we do. And all day, every patient gets an initial let me repeat, 3 hour visit. The usual visits are 10, 15 minutes with doctors. And
Right.
they're so complicated, these situations. So 3 hour visits in general aren't even enough, but they're ridiculously overwhelming. But we've compromised to do that. And I've been there now 17 years, and I just wish I was earlier in my career where I am now. We would have done way more work. I've actually published more papers in the peer-reviewed literature coming out of San Diego than I did in my previous position.
Wow.
Anyway, that's not the issue. We're dedicated to providing care to individuals with sexual health problems to improve their life quality. That's all we do. And it's really, there's so few places that do that. There are
Yeah.
some that maybe do women only and men only, but we do the world of sexual medicine.
Yeah. And you're still offering those brief phone calls, right? To
Yeah, no,
consult
no.
with
Oh, yeah.
people.
Thank you for reminding me. we don't allow anyone to visit us unless they do what's called a courtesy call. So we do 10 minutes, 10 minutes of my time, no charge. And I do, like today, I'm doing 11 courtesy calls
Wow.
I scheduled today. So frankly, I think it's the most cool thing. I
Yeah.
don't know them, they don't know me. They're telling me the most intimate parts of their life, but they're so happy to have someone listen
Yes.
versus to be told, it's not my specialty. It's time for you to leave the office. I don't understand what you're talking about. Have a glass of wine because all this is your anxiety. And medical gaslighting for sexual issues is just bizarrely common. And
Yeah.
yeah.
Well, thank
All
you
right.
again for your time.
Jessa will do more. You're so much fun. All right. I'm gonna go to work now. Is that allowed?
Yes. Thank you.
I got my 11 courtesy calls today.
All right. Thanks, Dr.
All right.
G.
Have a great day.
Bye
Thank you.
bye.
Bye-bye.